My name is Bianca Presley, and I am the Program Consultant for the American Heart Association. Today's webinar is supported by Philips Image Guided Therapy. I'd like to begin by going over a few items so you know how to participate in today's event. The link for live captions can be found in the question panel for your convenience. If you would like a copy of today's presentation, you can download a PDF from the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing the browser. If that doesn't work, please review the system requirements or contact the GoToWebinar customer service team using the system requirements link found in your confirmation and reminder emails. At the conclusion of today's presentation, you will receive a link to access today's recording, a completion certificate, an invitation to complete our feedback survey as well. We welcome you to submit text questions for our presenters at any time in the questions pane of the control panel. We will collect your questions and address them during the Q&A session at the end of today's presentation. As many as 1 in 20 patients with a cardiac implantable electronic device develop an infection within 3 years of implantation. Gaps and delays in recommended care for CIED infections are all too common and can lead to preventable illness, disability, and death. The American Heart Association's National CIED Initiative for Infection seeks to address the gaps in awareness, detection, and appropriate treatment of cardiovascular implantable electronic device infections. For the latest information about upcoming events and other resources on this topic, please visit heart.org/treat2beat-CIED infection. That's heart.org/treat2beat-CIED infection. We are excited to announce the launch of our CIED infection toolkit available on our website for review and download. Use the CIED infection toolkit as a resource both to learn about CIED infections and to increase awareness of the public health burden of CIED infection and urgency around timely infection identification and evidence-based treatment. Now, it is my pleasure to introduce our panelist and moderator for today's webinar. Dr. Doherty is the Spence Professor in Nursing at the University of Washington School of Nursing and an adult nurse practitioner in cardiology at the VA Puget Sound Healthcare System, Seattle, Washington. Dr. Doherty is a nationally and internationally recognized expert on recovery of physical functioning, psychological adjustment, and quality of life in persons who have suffered sudden cardiac arrest and have received an ICD. Most recently, she has conducted trailblazing research and exercise after an ICD, the importance of including the partner and intervention programs following initial ICD implantation, and goals of care communication in advanced heart failure. Dr. Doherty leads an interdisciplinary research team building a program of research that begins by systematically characterizing the experiences of those who survived cardiac arrest in Seattle, Washington. Dr. Doherty is currently the immediate post-chair for the Council on CV and Stroke Nursing for the American Heart Association. Dr. Doherty earned a BSN from the University of Nebraska, MA from the University of Iowa, and PhD from the University of Washington. Dr. Camerzell is a research scientist and internal medicine physician located in Overland Park, Kansas. He received a PhD in physical biochemistry at the University of Kansas, where he studied photophysics and structure-function relationships of biomolecules. Dr. Camerzell joined Genentech, Inc., South San Francisco, California, as a research scientist upon graduation, where he was involved with the experimental design and optimization of protein-based therapeutics. After working in the biotechnology industry, he returned to the University of Kansas and Washington University in St. Louis for medical training. He subsequently received the prestigious Sarnoff Cardiovascular Research Fellowship. Dr. Camerzell remains active in research and is currently an internal medicine physician with HCA. He continues to pursue research in the applications of machine learning and artificial intelligence in healthcare, and the electrophysiological mechanisms of cardiac arrhythmias. Dr. Kwaku is Director of Cardiac Electrophysiology and Assistant Professor of Medicine at the Gesell School of Medicine. Dr. Kwaku earned a Bachelor's of Science in Physiology from McGill University in Montreal and combined MD, PhD in pharmacology from Columbia University in New York City, where he conducted fundamental research on the biophysics of electrical defibrillation. He completed internal medicine residency at Massachusetts General Hospital and cardiology and cardiac electrophysiology fellowships at Beth Israel Deaconess Medical Center, both in Boston, under the mentorship of Mark Josephson, MD. Dr. Kwaku served as faculty at BIDMC and Harvard Medical School until joining Kaiser Permanente in Honolulu as Director of Electrophysiology, later serving as Chief of Cardiology. For several years, Dr. Kwaku was the only lead extractor in the state. He served on the editorial board of JACC, Clinical Cardiac Electrophysiology, and Circulation, Arrhythmia and Electrophysiology. Dr. Kwaku is a former member of the Board of Governors of the American College of Cardiology and a lifetime member and board member-elect of the Association of Black Cardiologists. Dr. Lacqueretti is the Executive Medical Director of the Kansas City Heart Rhythm Institute at HCA Midwest in Overland Park, Kansas. He has specialized clinical expertise and interest in electrophysiology, complex arrhythmia management, heart ablation, left atrial appendage closure, pacemaker, and other device implantation and management, cardiac resynchronization therapy, and pulmonary artery pressure sensors in heart failure, premature ventricular contractions, syncope, adult congenital and inherited cardiac rhythm disorders, and myocarditis. He serves as editor-in-chief for the Journal of Atrial Fibrillation, deputy editor for the Journal of Interventional Electrophysiology, and editorial board member and reviewer for more than 30 scientific publications. Dr. Lacqueretti is also very active in cardiovascular professional societies, including his chairman role for the ACC Electrophysiology Leadership Council, ACC Section Steering Committee, and Heart Rhythm Society's Global Relations Committee. Dr. Lacqueretti, the floor is yours.
So, ladies and gentlemen, welcome to this podcast on a very important topic, the cardiac device infections. This is a very disastrous situation when it is identified a tad late or poorly managed. And interesting enough, as the global population ages, the number of patients who received cardiac implantable electronic devices like pacemakers, ICDs, CRTDs continues to increase. And we have to be able to have a better finger on the pulse in order to mitigate the disastrous outcomes of CIED infections. And this podcast is especially trying to really build a multi-specialty across the stream sort of outlook towards how do we better identify these infections and how do we really manage these infections better, and thereby provide the superior care that our patients ultimately desire. So as it has been previously outlined by Bianca, we have an expert panel of physicians and clinicians on this. We have Dr. Cynthia Dougherty, who brings in a perspective from a special perspective from her side of the view. Dr. Camazel brings in from the internal medicine primary care standpoint, and Dr. Kwaku is a board-certified electrophysiologist who actually is involved in these type of procedures and extractions and stuff. So let me start off by sort of laying down a basic question about the barriers for the identification and the diagnosis of therapy. We know that the complete system removal is sort of the gold standard for CIED infection treatment. but this really requires accurate identification of infection. And we know that some of these infections are more obvious than the others, and some are difficult to diagnose, and there are a lot of factors that go into the mix. So could you speak to some of these difficulties clinicians could face when we try to detect and diagnose CIED infections? And perhaps, Dr. Kwaku, let's begin with you, because oftentimes I do come across patients that have cardiac devices, and they sort of talk to you. There are a lot of materials about various things that you find on the internet, but how come the cardiac device related information is so scanty? So maybe we'll start with expert, and then we'll kind of go around the panel as to what each one of your individual takes, or why there are so many barriers on this particular topic.
Well, thanks for that, Dr. Leccaretti. Good question. I'll start by saying that the patient who comes to you with vague concerns and perhaps vague findings has already sort of overcome perhaps the biggest barriers. That is that at least a question was posed that maybe this is not a normal pocket, or there's an infection going on, and the fact that something was going on that's not right for the patient was identified, and then a referral was made to somebody with expertise in trying to figure out whether or not there's a problem. So in my mind, there's sort of three broad barriers. One is knowledge base, knowing what is normal and abnormal, both from the patient standpoint as well as the greater clinical population that sees patients. In my opinion, no matter the setting, even if it's a 1-year follow-up in primary care, anybody with an implanted device should have their pocket observed, examined, palpated, and the findings documented. And then the other, as I mentioned, is the access not only to sort of routine care, but specialized care if there is a concern. And then finally, is the last barrier to overcome is the one to act. I'm sure we'll get into this, lots of different ways of managing CIED infections. And there's a whole host of barriers between going to total system extraction, as you mentioned, which is normally the gold standard, and just a lot of excuses that we find for patients of all types to perhaps not go that way. In your paper with colleagues and Jack just recently sort of laid that out using somewhat different words, but with the same idea of identifying patients, getting them to be seen by experts, and then that additional activation energy barrier to action.
Thank you. And perhaps we'll now switch to Dr. Doherty and see, Dr. Doherty, in your practice as a provider that sees patients in a lot more of a relaxed setting, and in fact, patients are probably more willing to talk to you and their issues than they are with a physician. So as a physician provider extender, what is your take on this, right? I mean, I think to some degree, we as electrophysiologists, we probably have a very skewed view of, we think these things need to be identified, and you get frustrated about all the little issues that come in the way of really providing appropriate care for these patients. And what is, in your opinion, one or two big barriers that you see could be solved?
So hello, everyone, and thank you for the question. I focus on, when I think about CIED infections, I think about the pre-procedure prevention strategies and post-procedure prevention strategies. And I have an algorithm I think about and apply to my thinking about both of those periods of time, but I'll talk now about post-procedure because I think that's where the question's going. When I think about, I try to empower patients in every possible way I can to help them, help us take better care of them, and providing excellent education for them pre-procedure and in the post-procedure space so that we have an opportunity to, number one, see the person back when we'd like to, and try to address barriers that prevent people from returning to follow-up care, such as transportation issues. They don't know when their appointments are. They don't have contact with us on a regular basis. They leave the hospital not knowing when their follow-up is planned, but also provide systematic education about what the expectations are for follow-up, how to reach us 24/7, what to do with a wound that doesn't look quite right to them, providing them photographs of what a normal wound healing looks like. So they might be able to look at their own wound and determine whether they need to contact us for help, to teach signs and symptoms of infection, to teach good wound care about cleaning the wound and the dressings and when you can shower and all of that. But because this webinar focuses on social determinants, to do some pre-procedure assessment of what those barriers might be in the environments that people live and work that may help them or prevent them from getting follow-up care and contacting us as soon as possible when they have a problem. I also provide them a schedule of follow-up that's expected in person, and which of those follow-ups could be done with telephone or video conferencing, and early on in the follow-up period to do everything possible I can to remove barriers to follow up and receiving care from experts who are aware of and know what a normal and infected wound might look like. So I think that might address what you're talking about, but I have other ideas maybe I'll come back to later.
Sure, absolutely. Otherwise, we still have the whole hour for us to talk about things. So thank you very much for that. And so, Dr. Camazel, you do take care of patients from a different vantage point. I'm sure a lot of these patients who have cardiac devices have coughs, colds, headaches, abdominal pains, chest pains, and a plethora of things that you take care of. How do you integrate this particular issue of the inability to timely identify CIED infections from a primary care physician standpoint?
Yeah, thank you for the question and being involved. As a primary care physician and a hospitalist, as you know, I take care of patients both in the outpatient and inpatient setting, and I think there are some different viewpoints as a primary care internal medicine doctor and hospitalist. So we can see the patient at different times and at different severities of a potential infection, which can create a challenge. And we may be the first line of defense and first line of contact for the patient who ends up developing an infection of their device. And so in the primary care setting, as an outpatient physician, as you know, we have limited time. So we see the patient who probably has multiple complaints. And if that infection if that device was implanted, 3, 4, 5, 6 months ago, but the patient comes in with some vague complaints, it can certainly be a tremendous challenge. I think one of the important points that we need to remember and educate each other on, including other primary care physicians, is whenever there's a device and there's any type of vague complaint of an infection, that has to turn on some red lights and some bells in our minds that, hey, this could be a potential source. And so, as Dr. Kwaku mentioned, and as an internal medicine physician, that patient needs to be examined. So we need to have them take their shirt off. We need to examine the pocket. Now, it can be a challenge if it's not a pocket infection and if it's more sort of low-grade sepsis or bacteremia, but still having vague complaints. So these are some of the things that I think about and that I get concerned about, and I think about how we can improve the process of diagnosis and identification of an infection of a CIED. Lots of other barriers that Dr. Doherty and Kwaku have mentioned in terms of economic stability, financial security, sort of health literacy and education that we can touch on as we move forward. But from my vantage point, oftentimes potentially being the first contact with the patient that may have one of these infections, it can be a challenge just simply with the diagnosis. I do believe that getting the patient, once that has been identified and diagnosed, to the appropriate specialist has been, we have a lot of barriers from that perspective as well. But that usually, from my perspective, at least in my practice, has not been a major barrier. So I hope that helps answer that question.
Yeah, no, I think there are a lot of similarities to the problems that we all face in this care continuum process. I mean, the vantage points are different, but again, at the end, the issue and the ultimate problem that we're dealing with is the same. And how do we really come together and put our brains together to tackle it, I think is the ultimate priority here. So based on that, I'm going to switch our conversation back to Dr. Doherty. And I mean, you've done some tremendous amount of work in really bringing down the barriers of the post-ICD implantation care in a lot of patients, and where the momentum is shifting from being healthcare provider-centric to a more patient-centric care. What, in your opinion, or maybe you have the sweet list of 5 or 10 things that you do or suggest to really empower the patients to be able to say, gosh, I have a device, it's my job to make sure that my device doesn't get infected, right? Like really putting it back in the hands of the patient. So what is there a sweet list of things that you would advise your patients to do, to watch for? I mean, you kind of mentioned a little bit of that in your earlier conversation. And what are the things that we as healthcare providers should be looking for, systematize it, canonize it, and then put it out there as sort of a guideline for preventing, managing, and effectively taking care of CIED infections? You're on mute, Dr. Doherty.
Sorry, trying to make sure you don't hear the trash truck. So thank you for that. What I thought I might do is talk about my systematic template I use in pre-implant assessment of the patient situation before they get an ICD, and I could talk more about post-procedure in a minute. But when I'm thinking about and doing pre-implant ICD discussion about whether a person is interested in receiving an ICD, that's part of the practice that I do now. I have sort of a 10-point checklist that I use in my mind to assess the possibility of a person being able to adapt successfully to the device, knowing what they're actually going to receive, and to help us take better care of them, including preventing infections. So I first insist that a person comes in for an in-person discussion before they get the defibrillator. And that's not only to give me an idea of some of these social determinants that may affect their ability to adapt well to the device, but also to examine the chest and the skin, and to go over their list of comorbidities and search the medical record for risk factors for infection that may be present that could be enhanced before the person receives the defibrillator itself. And that could include things like whether the person's on steroids, they're diabetic, they have a skin condition, they have end-stage renal disease, known vascular access problems in the chest, but more carefully, whether the person has poor dentition, whether they have a beard, whether they have tattoos on their chest, or they have any other condition that affects the external chest wall, where the defibrillator is expected, or under the arm, whether a defibrillator would be expected to be implanted. So an in-person assessment to see the condition of the person, their ambulation, whether they come at all with social support to the decision. So all of that assessment begins, as you all do, when you meet someone in the waiting room and you have an opportunity to speak with them about the the defibrillator itself. I also consider the person's age, knowing that there are special conditions of older populations and skin turgor and all of that in the chest wall that can cause difficulty, as well as knowing that younger people in general have more difficulty adapting to the ICD itself. Beyond that, I also am interested in their living situation. Where are they going to recover, whether they're a housed person or unhoused individual, whether they have access to electricity and water, food security, whether they have any social support at all, what's their transportation situation, who's going to be driving them to and from the procedure, and who will drive them back for follow-up for the first 2 weeks, and their preferred method of communication with us, such that they either have access to the internet, mobile phone that actually works, or a mobile phone that they actually know how to use, which all of you know is sometimes a difficulty for some individuals, and access to our ability to follow them in the post-procedure period and to do it successfully. I also introduce home monitoring at that period of time to see if that is even a possibility for us. So that's sort of my pre-implant checklist as I think about how I can help this person successfully recover from the implant itself and the likelihood or risk factors for infection in the post-implant period.
Great, thank you. And in fact, I mean, that really reminds me of this recent case that I saw. A 74-year-old comes in with a scar-etched scar. I mean, it's a dry gangrene type of a scenario with half of the device hanging out. And when I asked the patient about, so what happened and how did it really like transform into that? It really looks like a chronic infection that she never paid attention to. Obviously, her transport situation was terrible, right? She lives alone and she didn't have much of family or friends, and she doesn't own a car, so she's dependent on this meager transportation opportunities that she has to come from her town to either go to a primary care physician or to a specialist to visit. And so she's been nursing it in her own little way, whatever she thought was the best way to take care of the pacemaker incision, and that really didn't go well. So I think it really sums up the big gaps that we have in really understanding the social situation, providing the appropriate resources for these individuals to have a proper follow-up, right, and really creating that resource pool really becomes an important facet here. So thanks for touching on that. So let's now switch gears a little bit and move from this whole infection and then the patient education, all that, and talk more about the communication across the care continuum, right? I mean, so we have patients, we have primary care physicians, we have hospitalists, physician extenders, and then you have cardiologists and electrophysiologists. And in this whole care continuum, we see that there are a lot of gaps, whether it is lack of uniform electronic medical records, or what a primary care physician saw in their office not being communicated to the cardiologist or the electrophysiologist, or vice versa. So Dr. Camazul, this question comes to you. So what does the perfect CIED patient pathway should look like from your viewpoint, like from what you do both as an outpatient PCP and an inpatient hospitalist? What should this referral process should look like? Like, for example, you notice one of your patients had a device and you see a little bit of erythema, you're worried about infection. In an ideal world, how should we think we should navigate this care process for your patients?
Sure. So ideally, the patient has a follow-up with their cardiologist or electrophysiologist after the device is implanted, and assuming that is fine, comes back to me. I see all my patients in hospital follow-up within 2 weeks, actually, after their hospitalization. That is not the real world for a lot of patients, but ideally they come back and see me. Let's say that the infection develops 4 or 5 months down the road, which average time to infection can vary, I understand, but it can also be several months down the road. They come in to see me. If it's a pocket infection and there's erythema and I have a high index of suspicion, which I should, ideally, I would obtain labs. I would talk to that patient, and then I would I would refer them to preferably the person who implanted the device, or to their cardiologist. Ideally, let's say back to their electrophysiologist. If, depending on the severity of that infection, they may need to go back into the hospital right away. And so I may end up asking that patient and explaining the severity of that infection and say, hey, we need to get back into the hospital now. But initially, so depending on the severity and the timing, obtain some labs, blood cultures, and then refer back to the electrophysiologist that implanted the device for further care. And possible determination of what that next step would be. If they simply need, I would most likely provide antibiotics as well, but obtain cultures. So again, there's a little bit of nuance depending on the timing of infection. I'm getting a lot, so a little bit distracted here, but sorry. So timing of infection, severity of infection, and then knowledge of that device implantation electrophysiologist. So and then getting them back to that person. Again, there's a lot of barriers to doing that, but assuming in an ideal world we can do that, that in a nutshell would be a path that I think would be appropriate.
You're muted, Dr. Leckeretti.
That seems to really sort of plug in some of the holes that we have from that end of it. So Kevin, this question comes to you now. So you, as the electrophysiologist who implant devices and extract devices, I mean, obviously you are at a tertiary care referral center that has access to all the tools and all the support that you need to perform extractions. What's your take on what an ideal care continuum pathway should be once you put a device in a patient, and apart from the routine follow-ups that we all have, a patient comes back at 1 week to get the incision checked, and obviously they go back to their cardiologists and their primary care physicians. From that point forwards, what is an ideal patient care continuum pathway when there is a suspected case of CIED infection?
So, I work in a fairly low population density place in northern New England, New Hampshire, Vermont, and Maine. So the access points that were made earlier about transportation and that type of thing is very, very important here. Accordingly, many of our patients will come from a far further implant and be followed closer to home. And so to answer your question, I think it's critical for there to be a network of trusted physicians that have good relationships with each other, that have each other's cell phones, sometimes to cut through the various barriers that a hospital or an academic medical center may have to reach the right person and say, hey, I've got this patient. I'm sending you perhaps an image of their pocket or a description of their pocket. Would you see him? Or more often than not, at least in our center, it will be perhaps somebody that shows up in an emergency room and arrives and transfer, and then it becomes an inpatient consultation. And so, like Dr. Cameron had mentioned, really depends on the severity of the infection. Is bacteremia present? Is it a localized pocket infection? But this is part of the problem, right? Is that one size doesn't fit all. But I think one of the primordial issues is index of suspicion and level of awareness of physicians across the board. And that's where I think programs like the AHA's initiative is so critical to get the word out and to think about, say, hey, this is another source of infection. Perhaps we'll talk about, there are a number of networks, which does not yet include our own, where there's opportunities to implement even, AI or various alerting systems using the electronic medical record that will link patients maybe admitted or being seen for a second time with a recurrent bacterial, bacteremia. And they, by the way, they have a device. Has anybody put 2 and 2 together? And that's really going to help on the identification side for sure, and especially on the delay to treatment side, which we know has, real, potentially catastrophic clinical consequences.
I mean, I will add on one more layer to that. I mean, question or the topic that we're talking about. We recently did a survey called the Cognito Survey, looking at the potential barriers to identification and management of CIED infections successfully. One of the things that really fascinated me was the response of a large number of general cardiologists who felt that the risk of an extraction really superseded the benefit of one, which led to use of delayed extraction or total system extraction, more chronic antibiotic. They've already gone through 1, 2, 3, 4 rounds of antibiotics. I mean, you'll be surprised sometimes a patient has been treated with IV antibiotics for 3 months, right, with somebody with a device and a systemic bacteremia. And I'm very puzzled at this perceived sense of risk versus the benefit being higher. So what's your take on it? I mean, how do we really change this perceived risk being so much more higher? Is it because of the lack of access to an appropriate referral center that they can have the confidence that that patient's device can be successfully taken out? Or is it purely mere lack of education? Maybe this is a question that all three can answer one after the other.
Yeah, I'll give my first sort of hypothesis behind it. I think it has to do, first of all, it's a legacy thing. Atrial fibrillation used to be, AFib ablation used to be a treatment of last resort, and because it was so dangerous in the minds of many, and now it's really a first line therapy. We encountered the same thing with respect to anticoagulation. Some of our patients with atrial fibrillation who are at highest risk for stroke are deprived anticoagulation or left atrial occlusion devices because of perceived risks, when in fact the not doing that procedure carries a much greater risk. I think the same story holds true for lead extraction and system extraction when it comes to the entire device removal. And it's just really the same thing. It's a procedure that, although is not brand new, has not been with us for half a century for sure, and it has evolved. And not only have the tools evolved, but our experiences have evolved, and as a result, success has done nothing but increase, and the risk has done nothing but decrease. But unfortunately, opinions, memories are long, and also when something goes wrong with a lead extraction, it tends to be dramatic and memorable. Just the same way as the fear for anticoagulation. Somebody has a hemorrhagic bleed that they don't recover from. You think twice about it the next time you prescribe that pill. But again, it's just human nature. And the only way to surmount it, in my mind, is just sort of repeated education. And I think we've done that in the anticoagulation world, or we're really getting to there. And I think that programs like this, again, are really critical in getting the word out that there's actually, good data now to show the superiority of system extraction, except for very rare, exception.
Thank you. So maybe we'll switch it a little bit into more of the social determinants of health. Obviously, it's one of the biggest predictors of increased risk of infection. Poor nutrition, lower socioeconomic status, and access to care and communication, transportation are all big issues. Dr. Doherty, in your assessment, how do we fix these issues or take upon these social determinants of health limitations in really improving the care continuum of CIED infections?
So thank you for the question. Some of the ideas I have about what to do are not totally solidified in my mind. I think it depends on what your healthcare system provides and what is the availability of support within your local and your statewide community. But I think the first thing is to begin with a comprehensive assessment to determine where people are as they come into the procedure and make some create some interventions and support around the issues that you obviously see that are in front of you that can result in infection. And so if there's anything that you can do in the pre-procedure space to prevent post-procedure infections, I think that's well worth doing. And again, a comprehensive assessment might be very helpful. We might not have a strategy to be able to provide transportation, to provide high protein, vitamin C rich food, to help people with some of the issues that they're facing. But I think we should do everything that we can to involve our health system and our social support systems that are available to help us in the post-procedure period. I think a lot of it too has to do with bringing our patients up to speed with what it's going to be like for them to live with this device and how life might be different for them. And so they can begin to think about these things before they get the device itself. And most of the time, unless it's in a cardiac arrest space, getting a defibrillator is not an emergency procedure. You have some time to work through some of these issues to help people live successfully with a defibrillator after they get it. For example, working around whether you need to have some significant dental care for an infected tooth before you get a device implanted, whether you need to have a skin issue dealt with, whether you need to relocate yourself for a few weeks and live closer to the medical center to be able to provide up-to-date and timely care, in-person care. All of these things could be considered in advance. So I would say begin with assessment, know what your healthcare system can help you with, and then see where your gaps are and where you might be able to, as a system, fill in some of those gaps to provide the best care possible to all the patients. And, preferred communication style, preferred transportation, all of that's going to help you in the post-procedure space, as well as changing your service provided to something that I like to call, wraparound 24/7 care, in being able to access somebody with expert EP knowledge who is available on the weekends. And I'll give a quick example and then pass back. I had a patient this last week who left the hospital on a Thursday, and I saw the person in the morning, and the defibrillator was implanted on anticoagulation, and it was pretty swollen, significantly anteriorly swollen and sticking out, and asked the person to, watch that incision and pay attention to it, provide my telephone number. But the incision broke open over the weekend and was oozing black blood, and their strategy was, just put a piece of tape on that, and not important to get in touch with anybody. So by the time they contacted me, it was 5 days later. And so the incision had been open for 5 days at high risk for infection. And even though I was available, they, didn't contact me. I couldn't get the person in for care sooner because I didn't know about it. So people don't want to bother you, and they don't want to, they provide their own strategies. So
it's a missed opportunity in many ways, right?
For sure.
So, I mean, that really segues nicely into strategies for promoting equitable and evidence-based recommendations and communications. And oftentimes, I mean, it feels like we work in silos, even though we're dealing with the same patient and with the same problem. So, I mean, again, this will now go to a much bigger level of, and how do we really ensure that we develop appropriate recommendations, right? Like, say, during this cognitive survey, another thing that I found was more than 50% of the hospitals did not have a well outlined recommendation for how to manage a CIED infection. There is really no standard operating procedure. Like, I mean, we have SOPs for how to cut nails on a patient, but we don't have SOPs for how to really manage a CIED infection, right? I mean, I find that very, very interesting. And also the feedback that we received from the three groups of individuals, obviously, there are definite recommendations about CIED infection management for electrophysiologists that are part of a guideline. We have white papers and everything else because that's what you deal with. Not so the general cardiologists, and even not really that good in terms of the primary care physicians are concerned, right? So when we really take this a notch up, what do you think needs to happen at a professional medical society level, at a health system level, or an individual hospital/clinic level in coming up these guidelines or recommendations, standard operating procedures that would enable us to move the needle in educating our healthcare providers better than where we are today? Maybe I'll start with Dr. Kamerzel, then we'll go to Dr. Kwaku, and then to Dr. Doherty.
Yeah, so this is something that I thought a lot about before this, and I don't have the perfect answer, but what I can tell you is that it needs to be a multifactorial and an integrated approach. And I think that you've really started, this initiative has really sort of started that process. You need a group of champions who get together to come up with these guidelines that come from different backgrounds. And so you need your primary care physicians involved with your cardiologists and electrophysiologists and the other advanced practice providers. We need those folks to get together in a room to start to come up with ideas and champion it, right? And it needs to include all of these aspects touched on today, including education. So the patient needs to be educated before and after. All of the primary care physicians, they need to be educated, the specialists, and we can go about that education in different ways, I think, through things like guidelines and in peer-reviewed journals that might include Annals of Internal Medicine and the AHA type of journals, but having those printed guidelines to disseminate to our colleagues and talk about it at conferences. So that's one type of education, but there needs to be a multifactorial approach that certainly includes education in the traditional way that we have gone about education, and then use additional tools such as podcasts, which is what we're doing now, to reach other folks who get their educational materials in different ways, right? So a lot of people have moved to getting their content in different ways. So we need to use all of these available avenues to educate people. I also think that, and this was touched on, and I really liked what Dr. Kwaku said about the networks of people. Networks are extremely important, and I give my cell phone number. Sounds like Dr. Doherty gives her cell phone number to folks. I know Dr. Lackaretti gives a cell phone. Having those people that you can reach out to is extremely important. And perhaps we can come up with some guideline that develops a more integrated network that doesn't just include cell phones, but has some sort of network of folks that can really sort of champion this. These are a few of the things that I thought about. Integrating the tools that Dr. Doherty has developed into our EMRs, right? Integrating those types of tools, integrating alerts through AI and these things can be done, and they need to be done. And I think it's going to require all of these approaches in order to really, as you mentioned, move the needle. I'll pass off to Dr.
So, Kevin, what's your take on this? You're muted.
2 points I'd like to make. One is, yes, I think the gold standard is, the development of multi-societal, multidisciplinary, periodically updated guideline documents, right? That's really the gold standard in the field, and also when there's a go-to document that is available both in detail form and in executive, much more sort of to the point form that everybody agrees to is sort of the what is the SOP for any given infection, then I think that will help unify and level the playing field so that the care becomes more equitable across the board. I just wanted to make, since we're running low on time, I wanted to make a pitch here for with respect to digital health and how it can both help and harm us here. How can it harm us? We know that there's a digital divide socioeconomically, racially, and so forth, and not everybody having same access, for example, to telehealth. And also with the knowledge in the sense that certainly we know that there are major differences in terms of who receives remote monitoring. But even there, we each had our little anecdotes today of recent patients. I recently saw a patient, with a CIED infection who said, well, how come this wasn't picked up by my remote monitoring? Well, in a device in the future, that may happen. But right now, just what an interesting sort of knowledge and awareness gap that really is on the provider side to say, well, this is what this does, and this is also what it does not do. That being said, even undomiciled people nowadays have access to at least a rudimentary smartphone. And if you think of older patients receiving CIEDs, if they don't use their smartphone, they have a loved one or caretaker who does. And so I think that that is another tool that we should really leverage, both in communicating with patients and communicating between clinicians. And the last thing I would say, to bring it back to my concept about the guideline documents, that can be broken down and an app generated that people can have on their phone to help identification and next steps whenever they identify or suspect a CIED infection.
No, thank you. And since we're running tight on time, there was a bunch of questions that came through. I think we answered a lot of those questions during our conversations. And there's one particular question that maybe Dr. Doherty can spend a minute or so in explaining the role of social workers in bridging some of these big gaps that we have in post-procedural care. And maybe you can summarize it real quick, and then I'll do a final summary of what we learned today, and then we're going to close it.
So thank you. In our health system, and I work in my clinical practices in the VA, we have a strong interdisciplinary team that take care of all these patients with chronic health conditions, including in specialty care. So everybody has a primary care provider, usually in our system, and there is a series of groups of people, pharmacy, mental health, social work, that work together in primary care to deliver those comprehensive services. So we can reach out to our colleagues in other disciplines to help us with some of these tough issues that are around social situations and in communication. The VA even had a pilot program a couple years ago where they gave veterans who did not have a cell phone for a year to use to see if we could better coordinate their care. So I think there are innovative programs that are out there, and definitely just put a plug in for the Heart Association thinking forward that using some implementation science techniques and to sponsor some of these implementation of clinical practice guideline research projects could really help all of us.
Thank you. Well, this has been a fantastic session, really providing a panoramic view of the state of CIED infections. We have identified many of the barriers in the care continuum, starting from the patient through their flow, through primary care physicians, through cardiologists, through specialists, and all these other opportunities that we have. I think leveraging electronic medical record systems and really creating automatic alert processes, coming up with guidelines at an institutional level and guidelines at professional medical society levels, improving the cross collaboration, educating patients, educating referring doctors about the complexity or not of the procedure, earlier identification of infections, earlier aggressive antibiotic therapy, as well as a quick referral to specialized centers that are capable of full system extractions seem to be the way to go. And this is something I think that will continue to unveil, and we as medical professionals need to work together, bring our medical societies together to really improve our overall care delivery for these patients. Again, I thank all of you for spending time this afternoon with us and sharing your knowledge and thoughts with our audience. Thank you.
And thank you to our panelists, Drs. Doherty, Kwaku, and Camerzel, for your insightful contributions to this conversation, and to Dr. Lacqueretti for moderating today's webinar. This webinar is a part of the AHA Cardiovascular Electronic Device Infection Initiative. We recently released a podcast that reviews the patient case and discusses the importance of timely CIED infection identification and management. You can find the podcast as well as the recording of our past webinars on the initiative page, heart.org/treat to beat CIED infection. That is heart.org, treat the number 2, beat CIED infection. Again, we want to thank you for your participation in today's event. After today's webinar, you will receive a follow-up email with a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. In that email, you will also receive a link to view a recording of today's presentation and a certificate of completion. On behalf of the American Heart Association, thank you for joining us and have a great day. This concludes today's presentation.
Thank you.
Thank you for having us.
Thank
Thank
you.
you, folks. Have a good rest of the day.
Yes, well. Bye.